Next, let's talk about some hearing issues, ear problems, and the first thing we'll just talk on briefly is hearing loss, and that can be related to loud noises. It could be occupational or recreational. Then there are also classes of drugs that are ototoxic, and these can be certain antibiotics, aspirins, quinine. Also, allergies or eustachian tube dysfunction can impact your hearing. Having a buildup of wax in the ears can impact hearing, and specifically if the patient has increased ear canal hairs, hearing aids, if bony growths are secondary to some osteophyte or osteomia growths, and if there's ever been any previous episodes of impacted cerumen. And then also chronic middle ear infections can contribute to hearing loss. The first hearing issue we're going to talk about is tinnitus, and it's a very subjective finding. It's the perception of noise when in reality there's no environmental noise present. It may be described as ringing. It can be intermittent, continuous, or a pulse-like sound. Some risk factors could be hearing loss, inflammation of the labyrinth of the ear, Meniere's disease, otitis media or otitis externa, otosclerosis, and ear canal blockage, whether it be from wax or a foreign body. Other risk factors can be a history of high or low blood pressure, trauma to the head, anemia, allergies, and issues with the thyroid, chronic exposure to noises, medications that can have reversible effects such as salicylics, quinine, alcohol, indomethacin, and then some medications that can have irreversible effects, kanamycin, streptomycin, gent, vancomycin. So in the management of tinnitus, one of the first important things to do is to eliminate any offending medications, whether there be aspirin containing products or NSAIDs. So reviewing your medication record, helping the patient to learn how to cope with the tinnitus. It's important to avoid excessive noise when advised. Some research has shown that supplementation with vitamin A, vitamin C, B12, nicotinic acid, when out in loud noises, wear protective earplugs. There are devices that can mask the sounds of tinnitus, such as white noise machines. And the use of some antidepressants have been known to reduce some of the symptoms. These include nortriptyline, such as Elavil, that can be given at bedtime. Meclizine is the most commonly used medication for the management of tinnitus, especially if there is a vertigo factor. Next, let's talk about otitis media. And we know this can be the inflammation of the structures in the middle ear. You can have an otitis media with an effusion, which is a collection of plasma into the middle ear blood vessels, and this can lead to chronic effusions. Acute otitis media can also be called a suppurative otitis media or a purulent otitis media. You can also have recurrent otitis media, and it's the clearance of the middle ear effusions between acute episodes of ear inflammation. And then there's our chronic otitis media, which is inflammation that persists for more than 3 months. It's typically related to tympanic membrane perforation and can be intermittent or persistent. Just a few pictures on some ear issues. You can see that there's significant swelling here that's really occluding your visual field into the middle ear, and then here you can see the fluid that's collected behind the tympanic membrane. Ears are something that you have to get comfortable with. They're almost like fingerprints. Every person's ear can look different, so it's important that when you're in doing your physical assessments, even if it's something that is not ear related, take a peek in somebody's ear just to feel more comfortable with what different ears look like. Subjectively, when a patient complains of problems with their ears associated with otitis media. They may say their ears are full, they have stuffiness, they have a loss of their hearing in the affected ear only. Pain is usually rare, but if they do describe it, it may be described as a popping, crackling, gurgling sound when they're chewing or yawning. And sometimes there is occasional vertigo, but that is rare. With acute otitis media, you can have some deep ear pain and fever. There can be one-sided hearing loss. There can be discharge from the ear. There may be a recent history of an upper respiratory infection that could have moved bacteria down into the middle ear. You can have possible dizziness, some space disorientation. There can be vertigo, tinnitus, some vomiting, and nausea. Here are a few pictures of some chronic issues, chronic otitis media. You can see that the fluid is clear and so therefore not indicative of fever. In the chronic otitis media symptoms, there's a history of repeated acute otitis media that's followed by periods of drainage from the ear called otorrhea that can last for more than 3 months. Usually pain is not an issue with these patients. They can have hearing loss related to a hole in the tympanic membrane, which is one of the biggest concerns. Some signs of an effusion: the mucous membranes of the nose and the oral cavities may be reddened and swollen. The eardrum may be dull, but it is not bulging usually, and the eardrum mobility decreases when you're using a pneumatic otoscopy. When you're assessing objective signs of acute otitis media, the tympanic membrane may be an amber or a yellow-orange in color. It also may be injected with streaks of red. It may be pinkish gray to a fiery red in color. The tympanic membrane is typically full or bulging, and it may be difficult to see any bony landmarks and no cone of light reflex. For chronic otitis media, your patient may present with a perforated tympanic membrane that's draining. There can be a foul-smelling drainage coming from the ear, which could be an anaerobic bacterial infection. The color of drainage may take on a pus-type look. Bulla may form in between the layers of the tympanic membrane, and this can be caused by certain viruses or by the Mycoplasma pneumoniae bacteria. If you're finding that there are multiple perforations of the tympanic membrane, then that could be characteristic of a tuberculosis otitis. Management of the otitis media: if it's uncomplicated, it may be self-limited and require no specific intervention. The patient may need some pain eardrops for pain relief. If the patient is having a complicated or recurrent otitis media, then a treatment intervention is needed to prevent permanent damage to the middle ear and then to help prevent further hearing loss. In the book, on page 299, under Therapeutic Procedures 8.3, there's some pharmacology for acute otitis media in pediatric patients. Medications will be similar to adults, but dosages will differ. So with most management options for these patients, you can do wakeful watching. That is something that, depending on what your examination shows, if there's been a previous history of ear infections and how well your parents are responding, especially for little ones, to wakeful watching, all of that helps with antibiotic resistance. If you do have effusions that are persistent, then antibiotics may be appropriate, such as amoxicillin. If antibiotics have been used in the last month, then it's important to consider a beta-lactamase stable agent such as Augmentin or a third-generation cephalosporin. All right, let's next talk about non-allergenic rhinitis, which is also known as coryza. It can be infectious. It could be irritant related, such as in the workplace. It could be vasomotor, hormone related. It could also be associated with medication use or overuse of certain products. And then it can be associated with atrophy in the geriatric patient. Although the runny nose can be benign and self-limited, if it's poorly controlled, it can contribute to sleep loss, absenteeism from work or school, fatigue during the day, learning issues, in essence, decreased quality of life. So when your patient presents to you with some of these symptoms for viral rhinitis, it may be accompanied by malaise, headache, sore throat, and some occasional fever. If it's allergic, there may be itching of the nasal passages, itchy to the eyes and the roof of the mouth. You can have epiphora, which is stringy, watery, ocular discharge, and there also can be some sneezing, coughing, and a sore or burning throat. For vasomotor rhinitis, this is considered non-infectious without an eosinophilia, but there may be watery discharge, nasal congestion. It may have a nasally speech to the patient when they're talking to you, and they may be forced to have more mouth breathing versus nose breathing. Onset of the congestion may come on quickly. The patients complain of pronounced watery drainage, as well as a nasal obstruction that may switch from side to side. Treatment includes based on what you feel the rhinitis is stemming from. So as viral rhinitis, you need to treat symptomatically. For fevers and headaches, you may treat with acetaminophen. They may be treating the symptoms with an oral decongestant. There are nasal sprays that may help open up the passages, and then you could use dextromethorphan for persistent coughs. For allergic rhinitis, you want to avoid or reduce exposure to whatever the allergen is. Oral antihistamines may be appropriate for short-term treatment, and intranasal corticosteroids such as Flonase or Nasonex for long-term management, and then if necessary adding in a leukotriene receptor antagonist such as Singulair. All right, let's next talk about sinusitis, and there are different types: acute, subacute, and chronic. Acute is the abrupt onset of an infection and the resolution of symptoms that last no more than 4 weeks. A subacute is a purulent nasal discharge that persists despite therapy that could last anywhere from 4 to 12 weeks. And chronic sinusitis is considered episodes of prolonged inflammation with repeated or inaccurately treated acute infection that lasts greater than 12 consecutive weeks. The patient may present with some subjective symptoms such as a gradual onset in the symptoms. They may complain of recurrent or chronic dull, constant pain over the affected sinuses. The pain may increase and may become more of a throbbing to the area. In the maxillary sinuses, you may have pain over the cheek and upper teeth that may worsen when standing erect. In the frontal sinuses, the pain may be over the eyebrows and may worsen when lying down. And then the ethmoid sinuses, you may have pain over or behind the ears. So it's important to palpate these areas when you're doing your physical exam on your patient. Some objective signs of sinusitis can include purulent nasal secretions. There can be opacification of the affected sinuses if you're trying to transilluminate. The nasal mucosa may be red and swollen, and then the mucosa may have watery secretions to the point of some allergic sinusitis or rhinitis from the nose. You may have purulent secretions. It may be that yellow-green coming from the nose. There could be some black necrotic materials that you might see in your immunocompromised patients. The ethmoid sinus, and the involvement of this may result in chemosis, which is an eyelid mucous membrane swelling. You may also see some proptosis, some redness to the conjunctiva, extraocular muscle palsy, and some orbital fixation. There will also be the tenderness on palpation of the sinus. Management of the sinusitis. A large majority of your acute sinusitis attacks are viral, so antibiotics may be unhelpful, but antimicrobial therapy is indicated for uncomplicated bacterial sinusitis. Frequent nasal sprays of saline are very important to keep the sinuses opened and flushed. And then using a neti pot 2 to 3 times a day can help to keep the debris forming in the sinuses and to help infection to not develop. Other treatments for sinusitis is a cool mist humidifier, avoiding some environmental pollutants such as smoke and other external factors that may irritate the sinuses. Pushing fluids will help keep those secretions more liquid, and the use of heated mist for facial saunas from steam bath showers or hot moist towels wrapped around the face may help with the flow of the drainage and to help open up sinuses. Some medications that are used with sinusitis is some oral analgesics for pain, some medicated nose drops and sprays, prescription nasal sprays for 3 to 4 days, expectorants to help liquefy the sinus secretions, anti-inflammatory steroids to the nose, and then empirical antibiotics for 7 to 10 days if a bacterial sinusitis is suspected. Moving on, let's talk about some temporomandibular disorders. So these are a cluster of disorders that affect how well your jaw is able to move and how well you chew. The most common presenting symptom is pain with chewing in the preauricular area and around the TMJ area. Chewing or clenching or grinding your teeth and other jaw functions tend to aggravate the pain. Some subjective symptoms that you may notice for your patients with temporomandibular disorders include pain, which is seen in approximately 89% of the folks. They may complain of jaw noise, limited jaw movement, some ear symptoms, and only about 4% of the patients present with an obvious jaw dislocation. Management of these conditions is a multidisciplinary approach. You may need to refer to a dentist for a device to help with the grinding of the teeth. Your main goal is to reduce or eliminate the pain of the area and restore the function of the jaw. So decreasing its use can help. Changing from a regular diet to a soft diet may help with the chewing component of the jaw. Applications of ice or moist heat can help decrease inflammation of the area. Encouragement of the patient not to chew gum. Use the jaw as limited use as possible will help with the inflammation in that area. Other treatments for these conditions may include physical therapy. You can have therapeutic exercises and some electromodalities that PT may be able to offer. Behavioral therapy, stress relief, pain control methods that will then be used in conjunction with counseling, hypnosis, biofeedback, and guided imagery may help decrease pain to the area. And then there is pharmacotherapy that can help with the pain. On page 334 and 335 in the book, there are different medications that can be used to help with this type of pain. So please be sure and review those. And then on page 336, there's an iceberg diagram of the different modalities that can be used in the treatment of this condition. You know, the physical, the surgical, the pharmacological, support, self-care, psychological, and nutrition. So review those for help in educating and providing treatment for your patient. All right, that's the end of chapter 8, and thank you for your time.